Good morning. It's good to see all of you, or to see your profile pictures. Welcome to our first adult Sunday school study of the fall. I'm very pleased to introduce my wife Kate's uncle, Michael Schroering. He's the oldest of 8 children. He went to school and grew up in Louisville, Kentucky, went on to Holy Cross University on a Navy scholarship, is a Navy veteran, went on to the University of Kentucky Medical School. He served in Miami for a few years, then in Surrey, Virginia, and then moved to the Fairmont Clinic in 1984, where he was a physician there for 30 plus years. Just in my conversations with Michael, I've known that he has been an advocate all of his career for a more equitable kind of healthcare delivery system. And so he's been working and sharing this presentation in a variety of places. And I thought, Michael, you've got to come and talk to us at 6th and share your presentation with us. So I'm very happy and proud to introduce Dr. Michael Schroering. Michael, take it away.
Well, thank you very much. It's a privilege to come before you this morning and talk about healthcare in the U.S. I appreciate the fine welcome that I've received this morning. So we'll go ahead here if I can. So we will continue to hear much about healthcare this year as the presidential campaigns heat up. We hope to help you make sense of this complicated issue. Who are we? Dr. Agnes Franz, a retired pediatrician, Dr. Eileen Blacksburg, a retired internist, Ms. Pepper Hedden, a retired systems analyst, and I'm Mike Schroering, a retired family physician. All these persons helped assemble this presentation. I will start with case histories of 2 patients with type 1 diabetes that I cared for during my career. They were not the only patients abandoned by our healthcare system, but they illustrate the problem with our system. Both developed type 1 diabetes in their preteen years, and at that time they were covered by Medicaid. They lost their Medicaid coverage when they became adults. They were both caught in a catch-22. They needed a job to have health insurance, but they could not keep a job because of frequent hospitalizations brought on by a lack of access to insulin. Without insulin, they would develop very high blood sugars, triggering a condition in type 1 diabetics known as ketoacidosis. They would be brought to the emergency room, sometimes comatose, beginning a 3 to 10 day hospitalization. They would be discharged only to be re-hospitalized sometime in as soon as 2 to 3 weeks. These patients had only interrupted access to insulin. And because of this, their blood sugars were seldom controlled. They were rapidly developing the complications of diabetes, including heart disease, kidney disease, and blood vessel disease. The older of these 2 young men died in his 30s of heart disease, while the other young man died in his late 20s of heart disease, kidney failure, and by the time of his death, he had had multiple amputations. With access to insulin and good health care follow-up, these 2 people could have lived to their 60s and beyond. How is it that in the richest country in the world, our healthcare system let these 2 young men die prematurely? When I was a medical student and throughout my medical training, I frequently heard it said that the U.S. had the best healthcare in the world. But is it true? The World Health Organization, the CDC, and other public health concerns rank the quality of healthcare in the nations of the world by looking at various indices and measuring them. We're going to talk about 3 of these indices. There are many, but the U.S. performance in these 3 indices is fairly typical of their performance in the others. The first of these is life expectancy. In this slide, in 2017, if you were born in the U.S., your life expectancy was 78.6 years. If you were born in Italy, it was 83 years. If you were born in Japan, it was 83. In Canada, it was 82. The second indice, infant mortality, the death in the first year of life per every 1,000 live births. Again, in 2017, the U.S. had 5.9 infants die for every 1,000 live births. Contrast that with Sweden at 2.4 and with Canada at 4.5. Maternal mortality, the death of the mother for every 100,000 live births. Again, in 2017, the U.S. was 26.4 maternal deaths. Compare that with Australia with 1.6 and Canada at 6.6. So the U.S. did not perform well in these measurements. And the poor performance of U.S. healthcare is due to 2 factors: uninsured population and underinsured population. We all know what uninsured population is, that people had no insurance. The underinsured population had health insurance, but it was poor quality health insurance with high deductibles and high copays. Because of these high deductibles and high copays, the underinsured would hesitate to seek medical care when they got sick because they were afraid of the bills that it would generate. So it impeded access in that sense. And it worsened healthcare because they put off seeing the doctor until they really had no choice about it, at which time they may have found out it was too late to treat their condition, or if they did treat it at that time, it would cost much more than it would have had they seen the doctor when they first noticed their illness. So if they decide to treat it, they will generate the bills that they were worried about generating. And they would mount substantial debt. Many of these people would go to banks to get loans to pay off the debt, but that was just kicking the can down the road for many of them, and eventually they ended up with bankruptcy. Health care bills are the biggest cause of personal bankruptcy in the U.S. today. To reiterate this, these 2 groups, the uninsured and underinsured, not only have poor health outcomes, but many are just one hospitalization away from personal bankruptcy. Healthcare is the single most cause of personal bankruptcy in the U.S. today. How does this compare with other countries? Medical bankruptcy in 2018, the U.S. had 643,000 personal bankruptcies related to healthcare. How many did the UK, France, Japan, Germany, Canada, and the Netherlands and Switzerland had? They had 0. Now, I don't say that no one in Switzerland ever has a bankruptcy. I understand that rarely it happens, but most countries it doesn't happen at all, except in the U.S. So why does the U.S. stand alone among wealthy nations with greater than 500,000 personal bankruptcies a year related to healthcare expenses? Well, it's because the U.S. alone, out of all of these wealthy nations, is the only one that doesn't have a universal healthcare system that covers all the persons living in their country from cradle to grave. Are there other reasons that the U.S. performs so poorly when compared to other wealthy countries? Is it because we don't spend enough on health care? This slide shows the U.S. on the bottom in the blue and red bar. And what they've done in that is they've added up all the money that the government spends on health care and all the money that private insurance spend on health care. And per capita for that year, the U.S. spends $11,120 per capita for each and every one of us in the U.S. Compare that to these other wealthy countries. Most of them spend less than half of that. A couple, Germany and Switzerland, are a little over half, but no one comes close to the per capita expenditure of the U.S. of $11,120. So we spend plenty of money, but we don't get much bang for our buck. Why is the cost of healthcare so high in the U.S.? A few reasons. For-profit insurance companies are expected to award stockholders a dividend and to pay CEOs outrageous salaries. And the organizations are incredibly bureaucratic. We'll talk about the bureaucracy for a minute. This slide shows the percentage growth in upper-level administrators in U.S. healthcare from 1970 to 2016. And you can see there was a 3,000% growth, over 3,000% growth during these years. Compare that with the physician growth in the green part of the slide. And that may be 200%, which is in line with the larger population and with an aging population. Some more examples. Duke Medical Center has 557 beds and 1,600 billing clerks. That's more than one billing clerk for every bed in their hospital. If you go to a hospital of equivalent size in Toronto, you will find out that they have 4 billing clerks. Duke Medical Center also says the cost to send the bills for one primary care physician for a year is $99,000. Examples of outrageous CEO salaries. Outrageous is my term, but they're certainly high. In 2018, Humana's Bruce Bouchard made $27.2 million, and United Healthcare's David Wichmann made $21.5 million. Other reasons for high cost of healthcare in the U.S. The high cost of prescription drugs. The identical drug will often be 3 or more times as expensive in the U.S. as compared to other advanced countries. Even more ironic, the medications are often made in the same factory. I can remember 15 years ago when a popular statin drug was manufactured in the U.S. and marketed in the U.S. and Canada. It was 3 times as expensive in the U.S. as it was in Canada, even though it was made in the same factory. Why are prescription drugs so expensive? Again, CEO salaries and stock dividends, plus draconian pricing of drugs. In 2018, M. Reed of Pfizer made $47 million as CEO, while Ken Frazier of Merck made $48.4 million. As for drug cost, let's look at insulin. In 2006, this graph shows us that you could get your insulin for $198 for a whole year. By 2013, it had risen to $736. Today, if you're so unfortunate as to have to pay for your insulin out of your own pocket, it could cost $4,000 a year. A few more cost comparisons. Humalog insulin, a very popular type of insulin. The cost per vial. In the UK, it's 16 euros, which is probably, I'm guessing, about $25 for a vial. In Canada, it's $32 Canadian. In the US, it's $300 if you're paying for it by yourself. And this is an important point because those type 1 diabetics who've been on their parents' insurance until they turn 26 suddenly find themselves without coverage for their insurance, with insurance for the cost of their insulin. And there were many of them that tried cutting back on how much insulin they were taking. And this was a deadly scheme because many found that turning 26 was a death sentence. And there were documented numbers of young people who died because they couldn't afford their insulin anymore. This does not happen in other wealthy countries. Another example, EpiPen. It's a life-saving drug for those people who have anaphylactic reactions to bee and wasp stings. They have only minutes to treat themselves with a epinephrine auto-injector called EpiPen. And they cannot wait for the rescue squad to get there. They don't have that much time. And yet, for unexplained reasons, the cost of this drug skyrocketed several years ago. And these, as I've said, are life-saving drugs. And many people are dying because they can no longer afford them. This does not happen in other wealthy countries. Other wealthy countries use nonprofit insurance to finance their health care, and we're going to be talking about that for a few minutes. We're going to look at 3 models other countries use to provide their universal health coverage to their citizens. But before we do, let's talk about what they have in common. They use nonprofit insurance mechanisms. To see why this makes a difference, we will compare America's nonprofit private insurance with we will compare America's for-profit private insurance with America's nonprofit Medicare. This graph shows the insurance administrative overhead for 5 large health insurance companies. Let's look at Cigna. Cigna has an 18.4% administrative overhead. That means out of every premium dollar collected by Cigna from their policyholders, 18.4 cents of that dollar goes to administrative costs. Administrative costs are CEO salaries, stock dividends, marketing, their real estate, their utilities, their salaries for all their employees, and many other factors. That left 81.6 cents of every dollar went to the provision of health care. What about Medicare? What is administrative overhead for Medicare? Medicare's administrative cost is 2 to 4 cents percent. That means out of every $1 of tax collected from payroll for Medicare A, only 2 to 4 cents goes to administrative costs, with 98 to 96 cents going to the provision of health care. What Western Europe, Taiwan, Japan, Australia, New Zealand, and Canada all have in common is a reliance on nonprofit insurance. The healthcare plans of all advanced countries we have referred to fit into one of 3 models. The models are the Beveridge model, the Bismarck model, and the National Health Insurance model. Let's talk about the beverage model. The example is Great Britain. This is the only model where the label socialized medicine might be appropriately applied. In this model, all the hospitals are owned by the government. The hospital-based doctors and nurses are government employees. The primary care docs have private offices, but the patient's bills are paid by the government out of a tax fund. The second model, the Bismarck model, example is France. France has private nonprofit insurance. There are 14 insurance companies. It's financed by employer-employee contributions, much like Medicare A is. It's portable. If you change jobs, it goes with you. So if you are ending a job with Corporation A in the end of July, and you're starting one with Corporation B in September, you don't lose your insurance when you leave Corporation A. You continue with the same insurance and carry it to Corporation B. And during that time that you're not working at either place, you are still covered, unlike insurance coverage in the United States. Oh yes, you can get COBRA, but you'll pay a premium that you won't believe when you invoke COBRA, because you'll be paying what your employer pay portion was, plus your own portion of what your insurance was under Corporation A. The premium is paid by the government if you lose your job, if you're disabled, or if you're elderly. Doctors' offices are private and fees are strictly regulated. If you sit down in the waiting room of a French physician, you will see a sign on the wall that has all the exams and procedures that that physician does and the cost for each one of them. And this is required by law. Bismarck model, still talking France, there are no deductibles. There's a small point of service copay of about €6, most of which is reimbursed by the insurance company later on. All care is provided, no care is denied in France. France's healthcare has been rated the #1 healthcare system in the world based on patient outcomes. National health insurance, the third method. It's universal, covers everyone, cradle to grave. The doctor's offices are private. The hospital budgets are paid by the National Health Insurance. This is the model that Canada uses. And in this model, there are no capital projects without provincial approval. What do we mean by that? We mean if the hospital wants to build a new wing, they can't just build it. They have to present their justification to the provincial government, and the provincial government will just give them the money to build that wing if they think it's justified. And I think it's fair to say that you could go to any lobby of any hospital in Canada and you won't find a grand piano like you will at UHC in Clarksburg, West Virginia, because the Canadians would think that's an unjustified health expense. Now, I'm not saying that they would not provide a electronic Yamaha piano that can be taken from room to room to provide music therapy to the patients. But the patients in that hospital in Clarksburg, West Virginia, will never hear, most likely, the grand piano in the lobby. The national health insurance model in Canada is a single payer, meaning only one insurance company. And that's the government, which collects the premium as a tax. How did the U.S. get in this fix? A short history of health insurance in America will shed light on how we arrived where we are. In the early 1900s, some hospitals began offering insurance for their institution. Later, these separate institutions joined together to form what eventually became Blue Cross plans. The Blue Cross plans became a reality in the 1920s, covering hospital costs, with Blue Shield following in the 1930s, covering doctor's charges and outpatient charges. Blue Cross, Blue Shield at this time were non-profit insurances. During World War II and continuing in the post-war year, employer-based insurance became the most common, and it continues to be the most common private insurance to this day. In 1965, Congress enacted, after much debate, the Medicare Act. In 1970, Blue Cross Blue Shield nonprofits morphed into for-profit insurance companies. And if we have time during the question and answer period, we should talk about this very important change of direction. George W. Bush presidency brought Medicare D programs that provided assistance to the elderly, helping them pay for their medicines, and Medicare Advantage programs. This was a Medicare HMO. The Medicare D programs were a boom to Big Pharma, while the Medicare Advantage programs were a boom to the insurance company. Boom. Then in the first Obama term, the Affordable Care Act was passed. This act provided health insurance to 20 million people who were previously uninsured, but still left over 10 million uninsured. In addition, it forced new regulations on the insurance companies that required the following. Insurance could no longer be denied for pre-existing conditions such as diabetes type 1. Children could remain on their parents' insurance until age 26. Prenatal care, labor and delivery, and postnatal care were covered. Mental health, alcohol, and drug rehab treatments were covered on a par with other medical illness, when prior to this time, these programs were frequently underfunded. No capping of insurance coverage. For example, when cancer thought to be in remission resurfaces, care would be provided, not denied because of insurance limits. The donut hole in Medicare would be eliminated. Lab costs were covered. Preventive care was covered. Pediatric services were covered. And adult services were covered. All these covered services were part of the essential health benefits that were designed to provide a good foundation for the healthcare coverage of the ACA. The Affordable Care Act, Obamacare, also called Obamacare, was an improvement, bringing good health insurance coverage to millions who previously had no coverage, but still left millions uninsured. To make matters worse, from the time of the ACA passage to the present, insurance companies lobbied to repeal it. During the first year of Trump's presidency, Congress tried numerous times to repeal the ACA, but public outcry stifled their attempts. Having failed to repeal the ACA, its opponents urged on by the for-profit insurance companies began to weaken it by nibbling around the edges. They began by eliminating the insurance mandate, which undercut the financing of the plan. Congress relieved the wealthy of their responsibility to pay for a large part of the ACA by passing the Trump tax cut. Trump allowed the sale of low-cost insurance plans that did not include the essential health benefits that we discussed, the foundation of good health coverage. They did allow a lot of low-cost insurance that with high deductibles and high copays that would put their recipients at risk for bankruptcy in the future. The nibbling continues as we speak. In summary, we have seen how our present healthcare system fails to protect the citizens of many of our We have seen how our present healthcare system fails to protect the health of many of our citizens. The system not only fails to keep them healthy, but it endangers their financial security. Despite being the most expensive healthcare system in the world, it delivers dismal care to a large segment of the U.S. population. The high cost of our healthcare is in part due to for-profit health insurance and big pharma's draconian pricing of drugs. We learned that other advanced countries use nonprofit insurance mechanisms to control the cost of their very effective health care. If we are to protect our health and our financial security, we need a system that is universal, covers everyone, nonprofit to control cost, has no deductibles or copays to reduce the likelihood that people will go bankrupt, has a comprehensive essential health benefits as a foundation of its coverage, and has a method to rein in the cost of prescription drugs. Thank you.